Well, I'd like to share with you two cases where Oncotype DX changed my decisions and the decisions of the medical oncologists that I work with. One of the really important roles of Oncotype DX now is in post-menopausal lymph node positive patients who are estrogen and progesterone receptor positive. And I'd like to share with you two cases that really exemplify the importance of determining the Oncotype recurrence score in this category of patients. First is a 61-year-old patient who presented with a palpable breast mass. Core biopsy found that she had an intermediate grade invasive ductal carcinoma, which was ER and PR positive and HER2 neu negative. The patient chose a total mastectomy without reconstruction as her surgical treatment option. And when she underwent her total mastectomy, in fact, she had a positive sentinel lymph node. Our standard in mastectomy cases is to, in fact, perform a completion axillary dissection, which we did, and she ended up with a total of only the sentinel node, only 1 out of 18 positive lymph nodes. This 61-year-old was very healthy. Quite frankly, physiologically, she looked like and acted like she was in her 50s. And so typically there would have been a real tendency to want to give this patient adjuvant chemotherapy. She was reluctant to have it, terribly reluctant to have it, and only wanted to be on anti-hormonal therapy. But I insisted that we get the Oncotype DX analysis to really help us fine-tune our decision making. And in fact, her Oncotype came back with a recurrence score of 32. Now, therefore, she now knew she really needed the adjuvant chemotherapy, which she got 4 cycles of TC, did very well, and then was placed on an aromatase inhibitor until this day is doing very well. So Oncotype in this case was pivotal in actually convincing the patient of the importance of her needing adjuvant chemotherapy. Now, conversely, here's a second 61-year-old who again presented this time with an abnormal screening mammogram. Core biopsy demonstrated an intermediate grade invasive ductal carcinoma that was strongly ER and PR positive and HER2 neu negative. She actually chose a nipple sparing mastectomy as her treatment choice, and at the time of surgery, indeed, she had a positive sentinel lymph node. Now, once again, in mastectomy cases, in my institution, I think most elsewhere, we perform completion axillary dissections, which we did with her, and she ended up with only her sentinel node being positive out of a total of 12 lymph nodes altogether. She did great from her surgery, very happy with the cosmetic outcome, and once again, the Oncotype DX was going to be very important in our decision-making process. She was a very young 61-year-old who, like, again, most of my patients don't want chemotherapy if they can avoid it. And in fact, her recurrence score came back 12, and she indeed avoided adjuvant chemotherapy, was placed on an aromatase inhibitor, and to this day is doing very well. So in summary, here are two examples of young postmenopausal women, both of whom were lymph node positive, just 1 out of their total dissections, where the Oncotype DX results played a really pivotal role both ways in deciding what our treatment decisions would be. Do you know that not every breast cancer patient needs chemotherapy? Now there's a way to decide if chemotherapy will benefit you based on the unique biology of your tumor. To learn more about the Oncotype DX test and how to discuss it with your doctor, click this button.